Good afternoon all. Today we are going to learn about stroke, that is cerebrovascular accident. So stroke is any acute focal neurological deficit. It can be caused by the vascular lesions. So this stroke is sudden in onset and the symptoms will last longer than 24 hours if the patient survive. Okay, and there are two types of stroke. One is ischemic stroke and hemorrhagic stroke. So in ischemic stroke, the stroke can be caused because of thromboli and as well as emboli. Whereas hemorrhagic stroke, it has two types. One is subarachnoid hemorrhage and cerebral hemorrhage. Subarachnoid, there is a leakage of the blood in the subarachnoid space, that is called subarachnoid hemorrhage. Whereas in intracerebral hemorrhage, when there is a trauma or any blood leakage in the cerebellum, that is called as a cerebral hemorrhage. So there is one more type called transient ischemic attack. So this stroke is the stroke which occurs less than 24 hours. Okay, so it is a neurological deficit lasting less than 24 hours with complete clinical recovery and caused by focal hypoperfusion with the brain. The symptoms will not last longer than 24 hours. The person will recover within 24 hours. This is called transient ischemic attack. And today we will going to see about the treatment guidelines for this stroke. So the treatment guidelines is very simple. Okay, we have to start with antiplatelets. Some in hemorrhagic stroke we'll start with anticoagulants, and we have to give the secondary prevention. But the treatment is not simple as it looks, because the stroke should be treated according to the guidelines. Okay, so what are all the guidelines? Before we go into the guidelines, we'll study about the symptoms. Okay, if the patient is coming with the stroke, what are the symptoms we can see in that patient? Paralysis, okay. Blurred speech, then slurred speech, yeah. See, for a treatment of stroke, the diagnosis is very important. So if you diagnose the stroke as soon as possible, the patient will survive. Otherwise, the treatment is failure only in that patient. So the diagnosis of treatment, the time goal is only 25 minutes. Within this half an hour or 25 minutes, you have to diagnose the stroke. Okay, and the early diagnosis should be like fast. F indicates facial drop. A indicates arm weakness. And S indicates speech disturbances, and T indicates timely action. So these are all the fast recognition in the patient. So we have to recognize these things in early as possible. And all the patient we have to recommend CT and MRI and brain imaging, that is CT and MRI. ECG should be done, and laboratory tests like CBC, platelets, PT or INR, APTT, serum electrolytes, blood glucose, CRP, hepatic and renal chemical analysis. These tests should be done immediately and when indicated. So in some patients, extracranial and transcranial duplex or Doppler ultrasound should be done, and diffusion or perfusion MRI or perfusion CT, and chest X-ray should be done, and pulse oximetry and arterial blood gases analysis should be done, and EEG should be done. So these are all the diagnoses of the stroke. Next, coming to the major risk factors for the stroke. So there is two major types of major risk factors. One is modifiable risk factors, other one is non-modifiable risk factors. So non-modifiable risk factors, what are all the non-modifiable? One is genetics, one is age. We cannot modify age or genetics. And one more, race. One more, low birth weight, and sex, that male or female. Male are more prone to the stroke. And modifiable risk factors may be hypertension, diabetes, dyslipidemia, obesity, atrial fibrillation, metabolic syndromes, and obstructive sleep apnea. These are all the some of the risk factors which can be modified. But some of the risk factors like age and all, we cannot modify the risk factors. So coming to its treatment guidelines now. So we have to, this is the treatment guidelines for ischemic stroke. So the acute treatment will be, first we have to start altiplase. within 3 hours of onset. This altiplate drug should be started within 3 hours of onset, that is 0.9 mg per kg, maximum 90 mg IV, and 10% should be given as a bolus, and the remaining the 90% should be given within 1 hour, like over 1 hour. Okay, so this treatment should be given before 3 hours of onset. So what is the altiplate class of drug? Plasminogen activator, that is convert the plasminogen to plasmin and lyse this causes the fibrinolysis. Okay, and second option will be aspirin. Aspirin, the dose will start from 160 to 325 mg. It will be given daily, and this should be started within 48 hours of onset. That means after 2 days of treatment with altiplase. Okay, next, coming to its secondary prevention. This is only for ischemic stroke. Secondary treatment will be based on the etiology. So if the stroke happens because of non-cardio emboli, if it is not related to cardio, then we can start with the antiplatelet therapy like aspirin, clopidogrel, all those things, and aspirin, clopidogrel, and extended release dipyrimidine. Sometimes we can give only aspirin or clopidogrel separately, or we can give aspirin plus extended release dipyridamole. Okay, and in cardioemboli, if the patient is having an etiology of cardioembolic, because of cardioemboli the stroke has happened, it should be example like atrial fibrillation. So drug of choice will be warfarin, 0.2 mg per kg, and INR should be within this range, 2.5. And all the patients with the ischemic stroke, secondary prevention or hypertensive treatment should be given. Okay, so if the patient is previously hypertensive, start with AC inhibitors and diuretics. And if the patient is normotensive, it doesn't have any hypertension before, although we have to start with AC inhibitors and diuretics. And if the patient is dyslipidemic, start with statins. Even if the patient is not having dyslipidemic earlier, normal lipids should be, so even if the patient is having normal lipids, statin should be given. So this is the treatment guidelines, why it should be given, why the patient should, even though he doesn't have an hypertension, why we should start with AC inhibitors, diuretics will be seen now. Okay, altiplase. So everybody knows that altiplase should be initiated within 3 hours of onset of symptoms. So why we have to give? Because the early pharmacological reperfusion with IV and altiplase has been shown to improve the functional ability after ischemic stroke as compared to no intervention. So as soon as we start with the altiplase, there will be an recovery will be more. Okay, and the administration should be 0.9 mg per kg, and same like this, we have to give 10% as bolus, and remaining should be given within 1 hour. And what are all the adverse effects we can find? Bleeding. It's an antiplatelet, right? Bleeding. And so and the caution with this altiplase is avoidance of antithrombotic therapy like anticoagulants and antiplatelets for 24 hours after altiplase. We should not give anticoagulants or antiplatelets after starting with altiplase. 24 hours we should not give. Can you tell me the reason why we should not start? Anticoagulants and antiplatelet we should not start after 24 hours only. We should start with the antiplatelet and anticoagulant. Bleeding risk. So combination of drugs will cause more bleeding. Again, the patient who is having an ischemic stroke, he might get an hemorrhagic stroke. Then inclusion criteria. To start with this altiplase also, there is a inclusion criteria. So what are all the inclusion criteria? The person should be greater than 18 years of age. And clinical diagnosis of ischemic stroke with neurological deficit, onset of symptoms less than 4.5 hours. After 4.5 hours, if the patient comes to a clinic and with the stroke, we cannot start with altiplase. And contraindications of this altiplase is, in this patient we cannot give the altiplase. So like symptoms or imaging consistent with subarachnoid hemorrhage or acute cerebral hemorrhage, intracerebral hemorrhage. So if the patient is having intracerebral hemorrhage and symptoms which has been shown, we should not start with the altiplase. It will worsen the bleeding. And current use of direct thrombin inhibitors. If the patient is under thrombin inhibitors, if the patient is having any cardiac events like atrial fibrillations and all, they might be having a thrombin inhibitors. So in that situation, alteplase should not be given. And one more thing, use of treatment dose low molecular weight heparin in prior 24 hours, like infective endocarditis. And if the patient is having is under heparin dose, that in those patients also we cannot give alteplase. And if the patient is already having a bleeding disorders like gastrointestinal bleeding, in that patients also we cannot start alteplase. Next, coming to aspirin. So early aspirin therapy within 24 hours to 48 hours from the symptom of onset should be given to the stroke patient. Okay, and for patients who are receiving the alteplase, aspirin and other antithrombotic are generally held for 24 hours and after alteplase administration to reduce the risk of hemorrhage. And early use of aspirin in ischemic stroke patient is recommended by the AHA guidelines to reduce the long-term risk of death and disability. Okay, for that we have to give the aspirin. Next, coming to blood pressure management. Why we have to give the antiplatelets, antihypertensive agents in this patient? So in every stroke patients, the blood pressure will be elevated or will be decreased, right? So patients with elevated blood pressure eligible for the alteplase, who are eligible for alteplase, the treatment of hypertension to a goal of, we have to control the, like there is some goal for controlling the BP also in this patient. So the systolic blood pressure should be, they can maintain up to 185 mmHg blood pressure in these stroke patients. And the diastolic pressure should be less than 110 mg. Diastolic pressure and systolic pressure can be reached to 180 and 110 mg in the stroke patient. We cannot, like, okay, the BP is 180 now, we have to treat the BP and we have to come down. Like, we should not think like that. In this patient, if the BP is high also, the patient is stable and we should not try to decrease the BP. Why? Yeah, if so if in the stroke patient, if the BP is high also, their patient is stable and the blood flow will be good. But if you control the BP, the blood pressure will decrease, again the cerebral infraction will happen, again the patient may go to stroke. So we should not decrease the BP as sudden. And patients who are not requiring intravenous thrombolytic therapy like alteplase and or endovascular intervention, the use of permissive hypertensive and allowing BP to rise as much as 220 to 120 mg for the first 48 to 72 hours is often used as early initiation of antihypertensive therapy. So we can allow the BP to rise up to 220 and 120 mmHg. Okay. So for patient with comorbid conditions like diabetes or other comorbidities requiring blood pressure management, may be reduction of 15%. Only 15% you can reduce the BP, not more than that. And recommendations like, so in ischemic stroke patients with alteplase treatment, this is only I am telling in the numbers. Okay. So for pre-alteplase, before he receive the pre-alteplase, the blood pressure may be like systolic blood pressure can be controlled less than 185 mg and diastolic 110 mg. In patients who are not received alteplase, pre-alteplase condition. Okay. And in patients after received alteplase, the BP recommendation will be SBP is 180 less than 15 mg. Only 15% we can reduce blood pressure. And patients without alteplase treatment, the patients are not receiving alteplase treatment only, like if the patient got any hemorrhagic stroke like that. So the treatment benefit uncertain or not recommended unless BP is greater than 220 and 120 mg Hg. In the sense, if the patient doesn't in a alteplase treatment, it's not recommended to reduce the BP. It can be high also, 120 by 120 mmHg. Now coming to hemorrhage. So intracerebral hemorrhage. What are the types of intracerebral hemorrhage? Subarachnoid and So the treatment in this patient, the treatment of choice are mainly the procedures. Okay, so if the patient got an hemorrhage through cardioemboli, so what is the treatment of what is the procedure they will do? Angiography, stent placement, removing the clots. These are the procedures they will do. If the patient is not, the hemorrhagic stroke is not happened because of any cardioemboli, the treatment option will be anticoagulation therapy. Okay, so the first treatment of choice will be anticoagulant. What are all the anticoagulants? Warfarin. So 0.2 mg per kg. And in this patient also, the BP management should be done, but not more than, like, we have to maintain the BP. If the patient is having a 220 mg by 120 also, we cannot reduce the BP as sudden. And warfarin, so sometimes the patients who are taking anticoagulants also, hemorrhage can happen, right? So anticoagulants, what will do? Mechanism of action.
They will stop the coagulation.
Coagulation factors. Coagulation 9
If it will anticoagulants, it will cause more coagulation, right? It will, sorry, decreases the clotting. So if the patient is under anticoagulation, again the side effects will be bleeding in the hemorrhagic stroke. So in that condition, we have to give the, what is that? Antidote. So what will so the antidotes for warfarin will be protamine sulfate or vitamin K.
Vitamin K.
So vitamin K, the dose will be 10 mg IV, and with vitamin K we can give 4-factor prothrombin complex concentrate, that is blood. We have to administer the blood. And dabigatran, it's an newer anticoagulant, dabigatran, 5 mg IV. And sorry, for dabigatran is an anticoagulant. For antidote, idarucizumab. This is the antidote for dabigatran, 5 mg IV. And for rivaroxaban, we can give andexanet, andexanet alpha, 400 mg IV bolus at rate of 30 mg per minute, followed by 4 mg per minute IV infusion up to 120 minutes. What is the antidote for rivaroxaban? Andaxanet. Andaxanet alpha, 400 mg. For afixaban, same antidote, andaxanet, or blood transfusion. Secondary will be blood transfusion. So for any patient, we have to see for bleeding risk. For every who are under the stroke treatment, we have to measure the scoring system. How much the risk of bleeding in this patient. Okay, so there are certain scoring systems like as bleed score, stop bleed score. So these are the scoring systems we have to do for those patients to know how much the risk factor in this patient for the bleeding, and then we have to start the treatment. Okay. Thank you.